On termine par cette session de pathologie vasculaire pulmonaire et on va commencer par la première présentation qui va traiter de l'embolie pulmonaire à faible risque. Le meilleur score et la prise en charge se fait-elle en ambulatoire ou en hospitalier? Pour cela, on a mon ami LAAREJ dont on regrette l'absence avec nous, l'absence physique, et qui va nous faire la présentation en vidéo. À toi la parole, Hanan.
Bonjour tout le monde, je suis très contente d'être parmi vous virtuellement. Malheureusement, je n'ai pas pu être à Agadir physiquement pour des raisons. Allô? Est-ce que vous m'entendez bien?
On t'entend très bien.
Je ne vous vois pas malheureusement. Très bien, merci.
On t'entend très bien, vas-y, tu peux y aller.
Alors, je disais que c'était un plaisir d'être parmi vous virtuellement, même si pour des raisons qui sont plus fortes que moi, je n'ai pas pu être présente parmi vous à la magnifique ville de Agadir. Je remercie d'ailleurs l'association Amar et la faculté de médecine d'Agadir, à leur tête, professeur Hind Farhan, qui est mon ami avant tout, de m'avoir proposé ce thème intéressant et surtout de m'avoir proposé de le traiter en anglais. Je trouve ça encourageant en fait de changer la donne un petit peu, de s'ouvrir plus à cette langue qui nous permet d'être à l'affût des actualités dans notre domaine, où les publications sont souvent publiées d'abord en anglais avant d'être traduites. Alors, aujourd'hui, on va parler de l'embolie pulmonaire. Est-ce qu'il y a des nouveautés? Qu'est-ce qu'il faut retenir comme prise en charge diagnostique et thérapeutique? So, Bismillah, the pulmonary embolism is an obstruction of pulmonary arteries by diviral material. It could be thrombus, tumor, air, or fat from different parts of the body, but the most of time it's from the lower body. The incidence of acute pulmonary embolism has significantly increased over the past years due to the both increased incidence of deep vein thrombosis and also improved diagnosis by CTPA. So pulmonary embolism is a leading cause of hospital death and third common cause of cardiovascular death after myocardial infarctus and stroke. So what about diagnostic of pulmonary embolism? We all know there is several risk factors who could lead to pulmonary embolism, and we can divide this risk factor into strong risk like fracture of lower limb or hip or knee replacement, moderate risk like chemotherapy or blood transfusion, and weak risk like obesity, pregnancy, or diabetes. So the important part of stratification is there is several guidelines actually. The American one, the European one, the American Society of Hematology, the CHEST. It's a wide range of presentation from asymptomatic to death and mainly divided into low, intermediate, and high risk. It helps us to guide initial management and follow up, but it's not absolute. So the two scores who are best known and used are the Geneva one and WELL score. So we all know the revised Geneva score. It contains clinical factors and also clinical risk factors, and it leads to clinical probability. And the WELL score also, it's more American way to stratification of risk factors. So the question that we could ask ourselves is the WELL score is more effective than the Geneva score. Several studies were reviewed, and there's a review of Girardi 2020, and they all suggested a comparable performance, but however, the remaining studies found that the WELL score to be more accurate and discriminating pulmonary embolism than the revised Geneva score. So what about D-dimer's value? We all know D-dimers has negative predictive value, and the European Society of Cardiology in 1919 come with a cutoff, age-adjusted cutoff, calculated by multiplying the patient's ages by 10 when patients are older than 50 years. But this age-adjusted is very controversial, actually. Like in this study in Journal of Vascular Surgery, the conclusion was that age-adjusted D-dimer cutoff levels are falsely negative in 24%, and they are not useful for DVT diagnosis. What about imaging tests? Is there any new diagnosis of pulmonary embolism? Actually, no. We all know that CTPA are the method of choice for imaging the pulmonary vasculature in patients with suspected pulmonary embolism. But when we have a contraindication, we can also use the VQ SPECT. What about cardiac echography? So echocardiography examination is not mandatory as part of the routine when the patient are stable hemodynamically, but it may be useful in the differential diagnosis like pericardial tamponade, acute valvular dysfunction, or light ventricular dysfunction, aortic dissection, or hypovolemia. And conversely, an hemodynamically compromised patient with suspected pulmonary embolism, unequivocal signs of right ventricular pressure justify emergency reperfusion for pulmonary embolism if immediate CTPA is not feasible. So it's like an aid for physician if the CTPA is not feasible, and it could lead to reperfusion treatment. What about the etiology of pulmonary embolism? If we have a patient with a recurrent idiopathic thrombosis, or if the patient with pulmonary embolism have an age under 50 years, or a family history of VTE, or maybe unusual location of VTE like portal, hepatic, or cerebral vein, we have to do some tests like the factor V, the factor II, the protein C and S, and for the unusual location, we also add the JAK2 mutation. What is the diagnostic strategies? So the European Society of Cardiology make two versions, one without hemodynamic instability and one with hemodynamic instability. So when we have a patient without hemodynamic instability, we can assess the probability with Geneva or Wells score, and when we have a low or intermediate clinical probability, we have to do the D-dimer test. If they are negative, we exclude the diagnosis of pulmonary embolism. But if the D-dimer are positive, we have to do CTPA to confirm or affirm the pulmonary embolism. If we have a high clinical probability of pulmonary embolism, we can do directly CTPA without D-dimer test, and we can also confirm or affirm the diagnostic of pulmonary embolism. Now, when we have a patient with hemodynamic instability, we can do the cardiac echography. And if we have the right ventricle dysfunction, we can do CTPA, but if we can do CTPA, we can treat it directly the patient. If we can do CTPA, we do CTPA and we confirm or affirm the diagnostic of pulmonary embolism. So what about treatment of pulmonary embolism? So initial treatment is guided by classification of the pulmonary embolism severity as high, intermediate, or low risk. Several scores are proposed to assess the risk of mortality based on clinical parameters. The more known is the PZ score or the simplified PZ score. The parameters are the age, over 80 years, a history of a cancer, history of chronic cardiopulmonary disease, a heart rate over 110 BPM, or a systolic tension under 100 millimeter, or oxygen saturation under 90%. So patients classified as low risk in the validation had approximately 30-day mortality of 1 to 1.1% compared with 8.9% in the high-risk group. There are other scores actually, like the score of the European Society of Cardiology and the BOVA score or the new scoring system. We can also incorporate cardiac biomarkers like the BNP or the troponin into risk stratification, like in this diapo. When there is no shock, we can dose BNP or troponin. If they're high, we can do echocardiography. And if we have a right ventricular dysfunction, we can consider thrombolysis or embolectomy. So what is the treatment choices that offers us as a physician? There is thrombolysis, and according to current guidelines, systemic thrombolysis plus infractional heparin infusion is the first choice for the acute phase treatment of high-risk pulmonary embolism. For the intermediate or low-risk pulmonary embolism, routine use of primary systemic thrombolysis is not recommended actually. So when we compare the infractional heparin alone and systemic thrombolysis, systemic thrombolysis leads to more effective and faster clot dissolution and reduction and right ventricular overload. So the preferred thrombolytic regimen is intravenous administration of recombinant tissue type plasminogen activator. We can use, for example, 100 milligram over 2 hours. So there is a list of the absolute and relative contraindication to thrombolytic treatment. The absolute one is history of hemorrhagic stroke, ischemic stroke in previous 6 months, and the relative one is the, like, for example, pregnancy or traumatic or use of ECMO, advanced liver disease, etc. So what about anticoagulants? Most patients have low-risk pulmonary embolism, and their care can be managed at home with a direct oral anticoagulant. So the recent approval of a new oral anticoagulants like apixaban, dabigatran, and rivaroxaban has generated significant interest in their role in managing pulmonary embolism due to their improved pharmacokinetic and pharmacodynamic profiles, predictable anticoagulant response, and lack of required efficacy monitoring. So there is a comparison about anti-vitamin K and oral anticoagulants. We can see that for the oral anticoagulants, we don't need a specific diet, we don't need a specific monitoring, but the cost is more expensive, of course. So what about the other way to treatment? We have rheolytic thrombectomy. So the American College of Chest Physicians recommends an endovascular intervention only in patients with contraindication to fibrinolysis, primarily those with a high risk of bleeding. So similarly, European guidelines recommends endovascular intervention as an alternative to surgical embolectomy in patients with failed thrombolysis. There is also the transcatheter thromboaspiration. So advances in transcatheter technologies have made mechanical thromboaspiration a viable treatment option for patients with pulmonary embolism, particularly for those at high risk and with contraindication to thrombolysis, who represents up to 10 or 20% of hospitalized patients. So thromboaspiration catheters basically work by creating a negative pressure inside the pulmonary artery through an aspiration source, which allows for the aspiration of the embolus. So what is the treatment strategy? Where, what, and how long? So we can divide the pulmonary embolism into two ways or two ways. When we have a suspected high risk of pulmonary embolism, we have to stabilize we have to search for patient stabilization. So if we have a patient who's not stable hemodynamically, we have to reperfuse him. So we can consider ECMO if it's necessary. Like if we have thrombolytic contraindication for treatment, we can use ECMO or surgical or catheter embolectomy, or classically we can use thrombolysis. But when we have a patient with acute pulmonary embolism, we can anticoagulate him and in his home. But when we have an hemodynamic instability, we have to hospitalize him and check and assess the risk of pulmonary embolism. So if we have a right ventricular dysfunction, we can reperfuse him directly. If we have troponin negative or BTP negative, we can hospitalize him and do the CTPI. And the other reason for hospitalization is family or social support, or maybe a difficult access to medical care. So what is the treatment duration? Patients with acute pulmonary embolism should receive anticoagulants therapy for at least 3 months. So the decision to continue treatment indefinitely depends on whether the associated reduction in the risk of recurrent venous thromboembolism outweighed the increased risk of bleeding and should take into account patient preferences. So here is the international guideline-based algorithm for optimal duration and intensity of anticoagulation for pulmonary embolism. We could see different cases when we have active cancer, when we have anti-phospholipid antibodies, when we have minor transient risk factor. So we have different cases, and the decision is not easy almost of the time. So we can stop or continue anticoagulation. It's individual's decision. It depends on the patient. So what is the after pulmonary embolism? So patients should be followed longitudinally after an acute pulmonary embolism to assess for dyspnea or functional limitation, which may indicate the development of post-pulmonary embolism syndrome or chronic thromboembolic pulmonary hypertension. So there is a diagram or organigram who shows us a post-pulmonary embolism lifestyle recommendation. The first week, the first month, and a long term. For the first week, we have to encourage early ambulation as soon as effective. So lifestyle modification is also very important. Support patients toward a healthy lifestyle including adequate physical activity and smoking cessation, and physical activity, encourage stepwise sporting activity, and screen for sexual dysfunction. For the first month, we search after the pulmonary embolism syndrome. So we have to do echography, echography, and screen for anxiety or depression, and screen for cardiovascular risk factor. And a long term, we have to advise our patient about travel, physical activity, and anti-thrombotic regimen, review the use of antiplatelet agents, and continue encouraging a healthy lifestyle, including adequate physical activity. So in conclusion, pulmonary embolism is a common diagnosis and can be associated with recurrent venous thromboembolism, bleeding due to anticoagulant therapy, chronic thromboembolic pulmonary hypertension, and long-term psychological distress. So we have, as a physician, to assess our patients, and of course, the diagnosis is not sufficient. The treatment is not sufficient. We have to encourage a lifestyle, to reduce dose of systemic fibrinolysis. And thank you for your attention.
Thank you very much, Professor Hanan LAAREJ, for respecting the time and giving us some minutes for the questions. I would like to congratulate you for the overview on the pulmonary embolism. And I think the question will be in French or in English, as you like. Donc, on peut prendre des questions dans la salle si vous voulez.
Hi, Hanan. How are you?
Oui.
Fine. Professor Bakhatar. How are you?
Sorry, I didn't.
Professor Bakhatar with you.
Ah, yeah. Hello, Professor Bakhatar. How are you?
Fine. I will ask you about the score of embolism, and you have to choose about one score for the medical clinical office and one for the hospitalization patient. If you have to answer with one word, one for the office.
In my practice, yeah, I see. The score to decide when we or where we're gonna treat our patients, actually, in the hospital or at home. I usually use the PZ score, actually, the simplified one. It's more simple than the BOVA score or the WE score. So for my personal experience, I use the PZ score, the simplified one.
Est-ce qu'il y a d'autres questions dans la salle, en français ou en anglais? Professeur Hijam.
Thank you, Professor LAAREJ, for your...
Même en français, hein, si vous voulez
nice
poser
talk.
des questions françaises.
I am Mustafa Al-Hijam from the suburb of
Bonjour,
Paris.
Professor Mustafa Hijam.
How are you? How is everything? Thank you for your nice talk. Did you hear about a CT score that we published many years ago? Salah Din Khanadli and Mustafa Al-Hijam. And that score...
The CT score?
Yes, this is CT score for PE. We published this
Actually,
in 99. And it consisted of two parameters. The first one is the number of arteries that are involved by thrombus. And the second one is the degree of obstruction of the artery. Do you think that this index maybe has a place?
Actually, no, I didn't hear about it, but it seems very interesting. So the CT scan score. No, actually, I didn't hear about it.
CT score for PE. Do you think the aim of that score was to quantify exactly the huge of the PE in the pulmonary arteries? And do you think
And
that
it
it may
leads
have...
to...
You think it may have a place in the algorithm of the treatment of the PE or not? Thank you.
Okay. No, actually, I didn't hear about it, but it seems very interesting. And this score, it leads to a therapeutic decision, I guess. Do you hear me?
Yes, we hear you.
Okay. So I was saying to Professor that no, I didn't hear about the CT scan score actually, but it seems interesting, and I guess that this score leads to therapeutic decision if we can use faible analysis or not, maybe.
Is it okay for the answer? Est-ce qu'on peut enchaîner avec une autre question?
If you have any access to the publication, you may try in your practice to apply it in the management of patients, because you will have a real quantification of the PE and correlate it with the clinical features of the patients, especially the right heart failure and hypotension and other parameters in order to decide for the treatment. You may try to do that, because some teams it's not widely approved by the teams, but I think some teams use, and until today, this score published about 20 years before. Thank you.
Thank you. Thank you.
Thank
you for your interesting intervention. Thank you.
Est-ce qu'il y a d'autres questions? Are there any other questions? Suddenly, everyone talks English, talks very fluent English. So, est-ce qu'il y a d'autres questions dans la salle? Sinon, je passe la parole à ma co-modératrice, le professeur Daher Bouchra, pour la suite.